Well, hello, everybody. Welcome to IRG's Health Matters podcast. This is a podcast we talk about various health topics. And today, joining us on our podcast, we're going to welcome Dr. Anthony Yee. He's an orthopedic surgeon specializing in foot and ankle injuries. And anything that you need to know about your foot and ankle injury or surgical needs, you can talk to Dr. Yee. We're going to talk to Dr. Yee today about foot and ankle injuries, particularly Achilles tendon injuries and repair. Dr. Yee, how are you doing?
I'm doing awesome. Thanks for having me here, Shannon.
Thanks for joining us. We're going to talk about Achilles tendon, repairs and reconstruction and injury. And we're going to dig down in that. But coincidentally, we're just wrapping up Super Bowl 58. And I just want to mention to our listeners, if you all watched it, a great linebacker for the 49ers, Drew Greenwald, was running onto the field with the other players. There was a, offense, defensive change. It looks like he was getting ready to run on the field, jogged down on the field, went down to the ground, was injured. Come to find out, he had torn his Achilles tendon. So we're going to talk about how something like that can happen. But before we get into the injury, and I thought I'd just set that up because coincidentally, we're Monday after the Super Bowl. We're talking, just happened yesterday. Tell our listeners about your practice, your training. I mentioned when I introduced you, you're an orthopedic surgeon with some emphasis in training in foot and ankle. But tell us about your training and your practice. Let's talk there.
Yeah, I'd be happy to. So I did my orthopedic surgery residency training here in Seattle at the University of Washington. And I grew up not too far down in Tacoma, so mostly a local guy. And then after residency training, I decided to pursue a fellowship in foot and ankle surgery. And so I did that out in Boston at Harvard Brigham and Women's Hospital, where I got to work with some awesome mentors, learn a lot of really cool strategies in the operating room. Got to meet a lot of really cool patients. And, these are things that I really strive to apply to my day-to-day life interactions with patients, trying to get people back on their feet.
Okay, let's talk about this, guys. Our listeners are probably thinking to themselves, fellowship, residency. Let's drill that down a little bit so they really understand what you're talking about as far as your training. So just real quick to summarize, you do 4 years of undergrad in college. You go to 4 years of medical school where you learn medicine, and then you choose what direction you're going to go. And as an orthopedic surgeon, you're going to do 5 years of surgical training, right? And then you decided after that 5 years of surgical training residency, you want to do a fellowship in foot and ankle surgery and injuries. And you talked about your mentors, but for our listeners, that fellowship, that 1 year is extensive training in just injuries and repair and surgical interventions of the foot and ankle. Is that accurate to say?
Yeah, that's a great summary of that. So during residency itself, the 5 years, you get a broad exposure to all different facets of orthopedic surgery from head to toe, whether that's, sports injuries, hip replacements, children, you name it. And then during that time, I was really drawn to foot and ankle because it has so many different parts to it. You get to work with a lot of different kinds of patients. And so I decided to do an additional year of fellowship training specifically within the foot and ankle.
And that in that 1 year of fellowship training, it is primarily just treating foot and ankle injuries and surgical intervention, and that's all you see for a year. So by that time that year is over, you are fellowship trained, but really an expert in all areas of foot and ankle injuries and surgery in all populations. Is that pretty accurate?
Yeah, I mean, I got to say that year I learned probably the most I have in my life. Working with some awesome mentors, teaching me their, many, many years of wealth of knowledge and tips and tricks and pearls, in and out of the operating room, whether it's, in the operating room or in the clinic. That it was amazing.
Yeah, for our listeners, I mean, we talk about your hand. I mean, your hand is a very complex structure. I mean, you look at the number of tendons and nerves and ligaments and muscles that control your fingers and your thumb, and it's very complex. But then just add that to your foot and ankle and the complexities there. I mean, significantly complex, particularly if you hurt your foot and ankle and then all of a sudden your gait changes or you can't walk. I mean, limited function. I mean, anybody out there that's ever stubbed their toe, sprained their ankle, boy, you appreciate your foot and ankle. When you have to stand on your feet and ankles all day long, it's the foundation of the body. Maybe anatomically, let's just set up from your standpoint the complexities of the foot and ankle. And you mentioned that you really were drawn to that area, and I'd like to know why, from an anatomical and just muscular and just everything that what drew you to that area. Can we kind of talk about the anatomy of the foot and ankle, how complex it is, Dr. Yee?
Yeah. So the foot and ankle, just like you said, there's a lot of moving parts, a lot of small bones.
Tell me about it.
Some really small, some a little bigger, and very, very uniquely shaped bones. I think it's hard to find bones anywhere else in the body that are as unique as a lot of these bones. And so that makes up for the potential for being able to do really cool things with your foot. Just like you said, it's the foundation of our base. We need it for day-to-day life, and we also need it to do the cool things that we love doing, like sports or participate in the Super Bowl. So yeah, there's a lot of moving parts, a lot of ligaments holding different things together. But whenever there's a complex, series of relationships between bones, there's also the potential for something to go wrong. And so one of the parts that I love the most about my job is, one, figuring out which part has gone wrong and how we can make it better.
Yeah, I mean, and obviously you've got some great training, and we're going to talk about one of the particular areas of the foot and ankle that sometimes we hear about, and that's the Achilles tendon. I just mentioned in the Super Bowl, linebacker Drew Greenlaw walking on the field, no contact, just running on the field. All of a sudden he goes down immediately, and he has this diagnosis of Achilles tendon injury. Well, let's talk about the Achilles tendon and how it's so important, but let's talk about how it's injured. Let's talk about the partial tear, complete tear, how you treat that, and we're going to get in the weeds of an Achilles tendon injury. When does it need to get repaired? How is it torn? And how do you come in? And we want to talk about this Achilles speed bridge is really what we're going to dig into. So tell us about the Achilles tendon, and it's a very important structure. If you tear it, you can't move your foot. But maybe we can talk about the muscles that make up the Achilles tendon. It's a very large tendon. I believe it's one of the largest tendons in the body. Maybe tell us a little anatomically about the Achilles tendon.
Yeah, absolutely. You're right. The biggest tendon in our body, and as you know, the tendon was what connects a muscle to a bone.
Mm-hmm.
So a muscle has to be connected to something to be able to transmit force. And in this scenario, it's your big calf muscles, or the gastrocnemius and soleus, that sort of blend together to form a big tendon, the Achilles tendon, that connects to your heel bone or your calcaneus. And that's what's responsible for allowing us to push off. So that's important for just day-to-day life. For example, when you walk and you strike your heel on the ground first, and then you go down, you put your foot flat down, and then you push off, and to be able to propel yourself forward just for day-to-day walking. And then you could also imagine that's extremely important for the athlete in terms of being able to push off for power, sprint, those types of activities. So you talked about injuries to the Achilles tendon. So ruptures can happen in different ways. The classic scenario that I see is someone who may have had some background of tendinopathy or an unhealthy tendon that was just sort of nagging them for a few weeks or months, and they are playing a sport, maybe something like basketball or pickleball, and they're sort of rocking forward to push off of their leg, and they feel a big pop at the back of their heel, and they look around because they think that someone kicked them in the back of the heel. But sure, sure enough, there's no one around them. And then, I've had people been very, very adamant that someone just kicked them in the back of the heel, but there's nobody next to them. And next thing they know, they're on the ground holding their ankle. But there are also some more unusual ways I've had, for example, rock climbers, sort of having an accident and coming down and very forcefully hitting the wall with the bottom of their foot, and that just causes a ton of tension across the Achilles, and that can rupture. And then the more unusual ones would be more of like a laceration where it gets cut. I've had patients that unfortunately have really sharp objects, like sometimes, for example, the edge of a metal box come and hit them, but those would be more unusual. I'd say the more classic scenario, someone playing sport or pushing off with it, all of a sudden feel a pop and they go down.
Yeah, I've been playing basketball. Years ago, I was playing basketball, and one of the gentlemen I was playing with, running down the court, I mean, same thing, just all of a sudden went down, and literally, you're exactly right. You heard a pop, and they thought someone kicked them, went over there, I assessed them. You do this test, you kind of squeeze it, nothing moves, you've torn your Achilles. It's pretty apparent. Before we get into the complete rupture and the tear, I want to ask you, generally speaking, this is more of I'm just going to summarize here and just correct me if I'm inaccurate, but probably more of a male. You probably see it more in males, and I understand it's like 36 to like 45. Is there an age range, the data statistics that tell you who this happens to most frequently?
Yeah, you're right. I think classically, the classic story is a middle-aged man, like sort of the weekend warrior, if you will.
That's me. That's me, by the way. Go ahead.
Yeah. Not always, not necessarily engaging in regular exercise, but here and there, going out and playing some ball. But I'll be, just anecdotally from my personal experience, I've actually seen a slight shift. I'll be honest with you, I don't know exactly why, but there seems like a shifter to younger patients as well. I see a good amount of patients, unfortunately, in their 20s, 30s, who come in with Achilles tendon ruptures, but similar mechanism, similar story that I've seen in the past few years.
Dr. Yu, when you hear that or see that, and the patient describes, that loud pop, and then lack of function, they can't move their foot into plantar flexion, and et cetera, that's generally, we're talking about a complete rupture, which the tendon generally tears off that calcaneus bone or that heel bone. Before we get into the complete rupture and the repair there that's going to be needed, tell us about those patients that maybe you see that have, quote, what that you call or maybe determine as a partial tear. Tell us about those symptoms and tell us about that treatment, and then we'll get into the complete tear if you can.
Yeah, absolutely. So those partial injuries, and often like a strain, so a partial tear of the tendon, there's still fibers running across that are intact and it's still working, but maybe not to its full extent. In those scenarios, it's usually not as painful. They may not have heard the classic pop. And then as a clinician, the most important thing is listening to the patient's story and then also examining the leg.
Right.
And in those partial scenarios, you're unlikely to feel a gap. Usually in a full rupture, you put your hands, you can run it along the tendon, you can feel a gap across. That's very striking. And as you mentioned earlier, that test that you did on that on your when you're playing basketball, it's called the Thompson test.
That's right.
So you squeeze the calf, and you should see the entire foot flicker if the tendon is intact. And then usually in a partial tear, it's still intact, meaning you still see the foot flickering up because of the fibers being intact. And then some of the other things, if I'm still not sure sometimes it can be a little hard to tell, based because the patient can be quite swollen after a big injury, or if you're just not sure, a safe bet would be to get an MRI or put an ultrasound machine on it and look at it, to confirm your suspicions. But in most of the time, when in a partial injury, I'd say pretty much all the time, I'm able to successfully rehab a patient without surgery and get them back to doing things, and it's on a much faster timeline
Yeah.
than the full rupture.
Yeah. Now, when we talk about the rupture, because that's what we're going to dig into now, and I might have mentioned that. I mean, I don't know the data, but you talk about ripping the tendon off the calcaneus, which is the heel bone, and that's one way it tears. But you can also get a tear at the mid musculotendinous junction or mid tendon. What is more common? Where do you see the majority of these tears occurring, off the bone or at mid tendon?
Yeah, that's a great point. A great question. So I think the majority of these injuries happen at the mid substance of the tendon, and we think that's a weak point and what we call basically where the tendon experiences the greatest load or tension. And also, there's something called a vascular watershed, just fancy word for saying that the blood supply to that area is just not as robust as some of the other areas of the tendon. So you can think about our vascular system or our blood vessels like the roots of a tree.
Yeah.
And if one main root were more down by the heel and one were more up by the calf, and then sort of the very ends or the really small little blood vessels or the real little roots sort of go towards that sort of more mid-substance area. So it's not as good as a blood supply to that area. So we think that may play a role.
Interesting.
In that.
Interesting. So you're seeing majority of your tendons that rupture are at that mid tendon level somewhere, and you think, and the reasoning might be, just so our listeners can really comprehend this. So listeners, I mean, when your body does not have good vascular supply for some reason anatomically, that tissue is not getting those nutrients, oxygen, everything it needs. So it might essentially have some inherent weakness in that area. Is that kind of what you're saying, Dr. Yi? You thinking?
Yeah, exactly. It's sort of the most susceptible point where it takes on so much load and may sort of be at a disadvantage to begin with because of less blood supply to that area.
So if you see a patient that has that, we're going to talk about this speed bridge, and I would assume that the speed bridge is very useful when you describe it, and I know a little bit about it, but I would imagine that in these mid-tendon repairs, this is where this technique, the speed bridge, which is fairly new, really comes into, kind of action. Can you describe that?
Yeah, actually, so there are different variations of the speed bridge. So there's one for the mid substance, which is the one that's been in the media a lot for example, Aaron Rodgers.
Yep.
And then there's also an insertional speed bridge. So you mentioned the other kind of Achilles tendon rupture where it pulls off of the heel bone. That's a totally different animal. But there's also a speed bridge designed for that as well.
Wow.
There are some different nuances, but so you can use a mid-substance speed bridge, or what we call an insertional speed bridge, is the one where the tendon pulls off of where it attaches to the heel bone or the calcaneus. Both work phenomenally and make a really, really strong repair.
So the speed bridge is this, I mean, the word bridge, speed bridge, this is a device that you can repair mid-tendon tears or insertional tears. You can use either, I mean, one of the special devices for it. But what is the speed bridge? What exactly is it, so our listeners can really understand? Because you talk about Aaron Rodgers. I mean, they were talking about when he first had this done. This was the first game of the NFL season. So how many weeks ago, how many months ago? And they were talking about him potentially being back. And normally, without a speed bridge, a normal Achilles tendon repair is 8 to 10, maybe longer. I mean, to come back. We're talking rough numbers here. The speed bridge accelerates this, but describe what that is.
Yeah, so the speed bridge is something that was designed by a company called Arthrex. They're I don't have a relationship with them, but I use a lot of their products because they make a good product. I was actually able to go out to their headquarters in Naples for a few days and meet with some of the engineers and talked with some of the product managers, just the people behind the scenes that really push this technology forward. And it's awesome what they've done there. But the speed bridge is basically, you can think of it as a series of extremely well engineered strong suture that is able to be passed through the ruptured end of an Achilles tendon in a minimally invasive way. So, in other words, we can repair the Achilles tendon through a very small incision rather than having to go the sort of older, more traditional technique of making a large incision to really expose both ends of the Achilles tendon and run suture across it.
Wow.
And the way that it's done is, you can think of it as a really big, wide fork, or like a tuning fork,
Mm-hmm.
that you can adjust the width of to match the patient's anatomy. And after making a really small incision of a couple centimeters in length, you can run this device around the tendon itself. And it has holes engineered in it through which you can pass a special needle with these sutures attached to it, so that it goes through the tendon, through the skin, through the tendon. But because you have this special device, you can pass it in a way, when you pull out the device, that all the sutures are on the inside and just around the tendon itself.
Wow.
Um, and so,
And you're doing
and
this.
then,
You're doing this in a repair. Maybe I know we're on radio. It's hard to describe, but I mean,
yeah,
from a visualization, this is an incision that I mean. Previously, when I used to see post-op Achilles tendon repairs, the incision on the back it seemed like it was like 4 or 5, maybe even longer, because you had to go after those retracted tendons sometime, and it just took a lot of space to work in. You're describing a totally different working space. Maybe describe that.
yeah, absolutely. So this incision is can be very small.
Wow.
Sometimes 2 centimeters, maybe less, so like an inch long, maybe needing 2 stitches. So very, very small, as opposed to what you just described in terms of making a pretty sizable incision
Yeah.
on the
Yeah.
back. And I think one of the main benefits of doing it through this way has been that I sleep better at night knowing that we're able to get a nice repair through a really small incision, because going back to that idea of the blood supply issue. So just like you mentioned, blood supply is very, very important
Yeah.
to deliver oxygen, nutrients, and that allows for healing. And so if a surgical wound does not heal, that's a nightmare, where someone could potentially develop a wound complication, an
Mm-hmm.
infection, and we could easily end up in a spot where we're worse off than before. So being able to do it through a much smaller incision, it's much easier to heal that smaller incision. Really, decreases the complications like wound or infections, and definitely makes me sleep better at night. So that's super important. And then um, with regards to the um, the actual technique. So again, really small incision, being able to use this cool, well-engineered device that helps you pass sutures in a way that you don't have to make really big incisions. And then they've also cleverly figured out a way to even allow you to lock the stitches, meaning that you can literally water ski on this. So I know that
Wow.
some people might not want to hear about. It might be a little graphic, but you can have these sutures attached to the tendon, and you can lean back with your full body weight, and they will not tear out because it's locked in.
Wow.
Um, and then with the speed bridge construct, what you do is you pass them um, down towards the heel, and then you can anchor them into your heel bone. So that is about as robust, fixation as you can get. And part of the reason why we can really accelerate the rehab process for people that get a repair.
How long has this speed bridge been on the market? I mean, it sounds like it's pretty latest and greatest technique, but I'm sure it's been researched and studied. And in order to get these things in your hands as a surgeon, there's got to be a lot of data behind it. I mean, there's got to be a lot of research.
Yeah, so I think the initially the approval process to get something like this onto the market takes a very long time, and everybody has to do their due diligence to make sure it's first and foremost safe for the patient, and also that it works well. I'll be honest, I don't know exactly how long it's been on the market. But it's been a very nice tool in the toolbox, I'll say.
Yeah, sounds like it. And just real quick, Dr. Yee, so just so our listeners, I mean, this speed bridge is a device, and it's an engineered technique that allows you as a surgeon, basically, to summarize, a much smaller incision with better results. Essentially, I mean, getting better sutures to bring these two sides of the tendon that have been torn, bring them back together. Good, strong sutures, smaller incision, kind of a minimally invasive surgical technique, I would say. And this allows you to sleep better at night because you have a good procedure, good blood flow potentially, but also the patient is probably going to progress a little bit faster with this technique in their rehabilitation, i.e. Aaron Rodgers. So is that fair to say that the technique allows for a little bit more aggressive rehab on that end?
Yeah, absolutely. So the rehab, process, I'll be honest with you, not everybody is Aaron Rodgers.
Really?
A little bit of a unique situation.
I can't even do a 3-step drop back. I mean, go ahead. I mean, yeah.
But yeah, one of the ways that, as physical therapists and surgeons try to evaluate a patient's readiness to get back to doing the things they love. One of the metrics we use after an Achilles rupture is to see if a patient can reliably, if they've built up their calf muscle well enough after the tendon is healed. And one of the ways to assess that is to see if they're able to stand on that injured leg and do a good amount of heel raises. And I'll say, with this technique, and I know this is anecdotal and I haven't personally done studies on it, but I would say patients are reliably able to progress through that metric faster and more reliably. In terms of, the timeline, I would say a patient who's undergone this technique at 6 months out from surgery, on average, should expect to be able to be easing into high impact activity. They should be able to go for a run for a mile or two. Things aren't going to feel perfect, but should be feeling pretty good, which is, remarkable, especially in that, oftentimes, traditionally we talk about even closer to 1 year being sort of the point where you're reliably, at your new normal. And I'll say new normal just as a caveat, that, people are able to get back. I'd say a vast majority of people are able to get back to doing all the things they love doing, but it will not be 100% of what you used to have, but should be reliably getting back to doing the things that you love doing.
Yeah, getting back to doing things you love doing quicker with a smaller incision, with better repair, better sutures. I mean, this speed bridge. Now, I mean, does this device, the speed bridge, does it have? I'm just trying to get our listeners to understand this. It has multiple uses. I mean, you can use it. Obviously, I mean, tell us about how you. I guess what I'm asking is, do you have different sizes for different tendon sizes that you use?
The sizes are actually pretty standard across the board of the suture itself. I think they've engineered a suture size that's very appropriate, that strikes a balance between,
Mm-hmm.
not being too big, because if it's too big, then that can be irritating.
Yeah.
For example, this particular technique does not require any knots.
Ooh.
There are other techniques where you tie them off and create a knot, and so the knots can be irritating to people.
Yeah.
But then also on the flip side, you don't want it to be too small, because that wouldn't be as strong of a repair. And especially with being more aggressive in the earlier parts of rehab, you want to have something really strong to hold it together, because early on you're relying pretty heavily on the suture itself. But then as time passes, you'll rely more on the tendon itself as it heals and
Right.
matures.
Right. Is there any? I mean, does anybody that has Achilles tendon repair qualify for this speed bridge procedure? Or are there contraindications? I mean, are there things that you have to think as a surgeon when you're looking at this, or is this kind of across the board the best technique out there?
Yeah, I generally have a conversation with the patient. There are a lot of different ways to uh, repair an Achilles tendon.
Yeah.
Some of them are awesome, some of them not so great. Some of them are okay, just like in anything in life, I suppose. But um, there are some patients that, I'll talk about the pros and cons of each. Some patients just don't really like the idea of having an anchor into their heel bone.
Mm-hmm.
And they just say, you know what, I'm not a professional athlete. I just want to be able to do the things I love doing. So let's go with a technique that doesn't necessarily require something going into the heel.
Yeah.
So other people, want to do get back to things as fast as possible and as hard as possible, and at it as hard as possible. And the idea of the anchors into the heel doesn't bother them. I'd say it's actually pretty rare for people to have an issue with the anchor in the heel bone, but one of the rare things that can happen is that it can be irritating. And at some point they come out. But we've actually modified the technique of how we put it in. We've found that putting it in at a specific angle really minimizes the chances of it being symptomatic or painful for a patient.
Yeah, I mean, what you do is amazing. I mean, let me ask you a question just for our listeners. Is it fair to say that I think the goal here is to get that those ends of that torn tendon to reapproximate them, bring them together, have a good fixation with your sutures. But ultimately, isn't it? And just correct me if I'm wrong here, but I'm just asking it. Ultimately, that tissue heals, although it's scar tissue, it's not your genetic tissue, but that healing tissue, when it comes together and that tendon heals, that healing process is pretty strong still. I mean, I'm just asking.
Yeah, absolutely. So you're exactly right. So these tendons, when they heal, they heal with scar. So exactly like you said, not exactly what we had when we
Right.
were born.
Yep.
But it works well if we give it enough time. And the tendon just needs to mature, and it needs time to do that. And then exactly like you said, so there are some people that ultimately go down the route of non-surgical care for an Achilles tendon rupture, and that actually works, and it's actually amazing when you take a feel of it. Once it heals, you can just feel a solid tendon, and they're doing reasonably well. But some of the benefits and reasons why some people ultimately choose to go down the route of having it repaired is that what we found through studies are that there is a lower chance of it re-rupturing, and there's a lower chance, and then there's a better chance of you having better strength and endurance with the calf with having it repaired. And we think that that's because the surgeon can set the tension. So without surgery, we rely on using things like heel lifts to keep the foot pointed down, which helps the tendons get as close as possible. But if we repair it, then we can bring those two ends together and set the tension where it needs to be. And you can think about it as if a rubber band gets stretched out, and tears, it's going to work better if you tighten it up, as opposed to leaving it in a stretched out position.
Yeah, that's what a great point you make there. That length, tension, relationship to muscles and tendons, so important from the physics and levers that we talk about in our joints and movement. I mean, you can increase, you can bring that tension back where it's almost normal, and that's going to be better for that calf and soleus muscle when they start to strengthen up again. Essentially, that's the physics of it.
Yeah, absolutely.
That is amazing. I mean that's an excellent point. I wasn't really thinking about that. So the repair is good for that. Dr. Yee, I mean, is this would you say I'm sure you see a lot of foot injuries and you see a lot of different things in your office. Would you say your Achilles tendon is either partial tear or repair of the Achilles is a big part of your practice, or is this just an average day in the office for you?
I would say it's fairly common. Yes, it's one of the more common injuries that I see on a regular basis. But you're right. There's so many different kinds of injuries and around the foot and ankle, and that's why that's part of the reason why I love it, the diversity of it,
man,
and to really try to figure out what's going on and try to find a solution for it.
It is a complex area. Hey, just as we wrap up, I always like to ask surgeons particularly, I mean, your training is very impressive. Your techniques are improving. I mean, my gosh, I've been doing this 35 years. I started in this business as a physical therapist 35 years ago. Yeah, I know I'm an old guy here, guys. Just relax. But I mean, the techniques and the advancements, you're talking about this incision. Like I said, Achilles tendon, when I first started rehabbing Achilles tendon repairs, I mean, the incision was 4-6 inches on the back of the Achilles there, coming up and down from the calf, down to the calcaneus. I mean, not minimally invasive. The techniques are improving. Tell me, just as we wrap up, are you using any biologics? Is there any biologics that a surgeon like you, when you repair this tendon, would you put any PRP? Would you do any kind of biologics here to enhance that healing process?
I haven't done that specifically for Achilles tendon ruptures. I do know that there are some people around the country that do that.
Yeah.
I just don't know that there's enough evidence in terms of studies to make me go that direction.
Fair enough.
I think that PRP is an awesome tool and has some very real benefits for certain applications, and we're fine tuning our knowledge of where and when to use it. But currently I have not found a need to do that for Achilles tendon ruptures. It seems to want to heal.
Yeah.
As long as we treat it properly. And I will say, I'll put in one thing here that, whether someone has surgery or not, and you'll know this and appreciate this well, but physical therapy is absolutely critical. Probably the most important part of the rehab, whether you have surgery or not. So and it's got to be treated properly initially with heel lifts, staying off of it for a short period of time and slowly progressing. I sadly do see fairly frequently people that come in that never really got a diagnosis, or just thought they sprained their ankle, but it turns out it was an Achilles tendon rupture that just went on for a long time, and then it's turned into a chronic Achilles tendon rupture that healed in a stretched out position that's not functional anymore. So they come in, they've got pain in the back of their ankle, they can't push off, it's hard to walk, even day-to-day life is just really challenging. And that becomes a bigger problem. There are certainly solutions for that, but ideal to treat it properly on the first go around.
Absolutely. I mean, physical therapy thank you for saying that, is a huge component of rehabbing these Achilles tendon repairs. I mean, it's got to be done right. It's got to be done in the right process. One of the things that people need to realize is when you tear something, you get it repaired, and maybe you're in a boot for even 4 to 6 weeks, the atrophy that the muscles go through. I mean, muscles are one of these, if you don't, particularly weight-bearing muscles, if you don't use them, boy, they go away really, really fast. They atrophy, they shrink. It takes time to build those back up the right way. So that's good stuff. Hey, how would our listeners get a hold of you if they had some questions regarding maybe Achilles tendonitis, tendinopathy? Maybe they have someone that needs a repair, or just needs to have their foot and ankle looked at. I mean, you do more than just Achilles tendon repair. You take care of all injuries of the foot and ankle and all surgical intervention from the knee down. That's your area. That's your wheelhouse. Okay, how do you get a hold of you?
You could hop on to my website, which is anthonyyemd.com, or just type in my name into Google, or you can type in our practice's name, which is Orthopedic Specialists of Seattle, into Google, and we should pop up right there. And you can give us a call, send us a message, whatever suits you best.
And you have two locations. You're at both locations. You have a Wallingford and a Bauer location, correct?
Yep, right.
And you go between the two of them, and is that right?
Yeah, absolutely. And so I spend half of the week at each location there.
And that's AnthonyYemd.com. That's your own personal website, or your practice's website is Orthopedic Specialist of Seattle.com.
Yeah, correct. You got it.
And do you have like a telephone number, like 1-800-FOOT, FOOT? No, I'm just kidding. I'm joking. Yeah. Someone probably already has that, don't they? Hey, Dr. Yee, I want to just say thank you so much for taking time. I know you're a busy man, and you've got a lot going on. I tell you what, I appreciate your time. And more importantly, I learned a lot from you today, just on this speed bridge and some of the techniques you're using. And just the training, and so appreciate what you do. And in the hands of a good surgeon like yourself, there's a lot of options for people out there that have foot injuries. So again, thank you for sharing with us.
Hey, thank you, Shannon. I appreciate you having me on, and I always love chatting with you.
Yeah, thank you. Take care. Bye-bye.